If you allow me, I will introduce the next speaker, which is a good friend of mine, Professor Hans Reiber from Leiden. You will not believe me, but we have been working together since 1976, so that's almost 45 years. He was coming back from the United States and he introduced at the Thorax Center in Rotterdam and Erasmus University, the quantitative angiography. So we worked basically 3 years on an algorithm, which was the average weight of the first and second derivative of the brightness function. And what is amazing is that 40 years later, the algorithm is still solid and very good. And he has put a lot of energy to develop, to derive the physiology from the angiography. And that's what we are going to hear today. Hans, the floor is yours.
Professor Hans, one word. We also have very good remembrances of their labs. We went to Netherlands, got trained in some of those technologies, and that's how the QFire we are trying to get into our country. And if you see a core lab analysis, I think we'll first remember him, and that's how we requested him to share his experiences. You said FFR CT. We are in cath lab also. We are coming out with a solution for a cath lab based after angio. We will also get a CT. So let us hear about it from Professor Hans Reiber. Over to you, sir.
Well, thank you so much. Where is my? I want to share the screen. Why doesn't that work? Let me try that again. Do you see this?
Not yet, sir.
Not yet?
AV team, can you help us, sir? Saurabh?
Yes.
First of all, Patrick, for your nice words, and indeed we have been working together for such a long time, and indeed also now again on the QFR, and Dr. Kumar also for the invitation, and been a really pleasure to talk to you at this TCT India meeting. So, ladies and gentlemen, I would like to present to you the angio-based FFR approach that we have developed over the so many last years. We call it QFire, quantitative flow ratio. And the question was, as a title, is this the ideal solution for coronary physiology assessment in the cath lab? So what are the requirements for such an ideal solution? We believe that it should fit seamlessly in the workflow in the cath lab. It should be robust and fast, faster than the use of the wires. It should be associated also with less fluoroscopy time and less radiation dose. Of course, it should also provide the same values and the same threshold to the 0.8 as FFR. It should provide also more relevant data, the broader applicability, for example, 3D QCA for stent sizing, and of course not based on the wire nor on the usage of a hyperemic drug with less side effects for the patient, and also applicable to each of the coronary arteries and then pre, during, and post PCI. And we will also hear further about the value of the post PCI QFR, what quality, how we can use that to assess the quality of the PCI. Of course, available in heart team meetings to decide on the next steps for the patient. And with that, we believe, and I hope to convince you of that, that the QFR fits these requirements. It requires only 2 standard angiograms that are taken in the cath lab, 25 to 40 degrees different for the 3D QCA. We also need a flow velocity assessment that we do on the frame count. And for that, we need one acquisition of the two with a minimal of 12.5 to 15 frames per second. And then the pressure drop is calculated based on solid physiology principles combining 3D QCA and the flow velocity. To make things simple, and we have introduced a acquisition 8 with default values, the projections for the different coronary arteries, for the first view, and for the second view, of course, we need nitroglycerin to avoid any spasm, and a brisk contrast fluid injection for 3 cardiac cycles, either manually or by the pump, and of course avoid vessel overlap, and certainly not patient movement, and also not movement of the immunosensifier during the acquisition. In the right hand side you see the acquisition aid that we have. The view should be remain within this green circle. This is the current projection, and based on movement of rotation and angulation angles, we can determine what is the preferred second view. This is the layout of the current version 2.1 that will be released, and I will discuss later on in September of this year. Of course, you see the 2 views of a right coronary artery with automatically detected contours. This is the diameter function from the beginning till the end, and selection of a stenosis, proximal to distal, a 3-dimensional representation. We can, of course, there are multiple lesions here that we can select individually, and in this particular case, from proximal to distal and between the green circles here, we find that the delta QFire for this particular case is 0.18 on the scale from, of course, 1 till 0.78 at the end of the vessel, with a length of 28 millimeters, an MLD of 1.8, a percent stenosis of 49%, and a residual QFire of 0.97, which means that if we stent this particular lesion properly, then you can expect that the QFire of the vessel increases from 0.78 to 0.97, which would be a real great result, of course. And we also find in this case, and calculate the specific flow velocity of 24.7 centimeters per second. And we will hear later on and see later on why this is so important. The question, of course, is always you have to do a lot of validations, and we found that there are no systematic differences between the QFR and the FFR. Here, just 4 big studies, meta-analysis of the FAVOR trial, meta-analysis by Dr. Cortez in 16 studies, the NICE UK report, 5,450 patients, Dr. Choi here recently. And if you add everything together, that's close to 10,000 patients. And you see that the differences here are all on the order of 0.01, plus or minus 0.01, and even 0.02, with an area under the curve of 0.92. So really, I think very nice results. We just mentioned if at the end of the PCI, the angiographic result may look good, but is it also physiologically a satisfying result? And there are a couple of studies that have shown the value of post-PCI QFR, and one of these is the first one, the Hawkeye study by Professor Campo. He did measured at 629 days follow-up after the procedure, that if the post-PCI QFR is less than 0.89, it was associated with a 3-fold increase in risk for vessel-oriented composite endpoint. And likewise, Professor Serraius also did another study where at 2-year follow-up, he found that also post-PCI less than 0.91 was associated with a significantly higher vessel-oriented composite endpoint. So one may say at the average 0.90 would be a very good value to determine success or expected success or not. This is just a clinical explanation how this can be used in the cath lab to determine which stenosis should be treated first. This is work done by Dr. Simone Biscaglia, also from Ferrara University, LED with 3 significant stenosis with a vessel QFR of 0.31, so really significant. And the question then is, which of the 3 stenosis, you see here the steps in the QFR, the pressure drop curve, which one should be treated first? If we look at, say, treating the second stenosis, PCI lesion 2, then the residual QFR would only increase to 0.65, so that doesn't help a whole lot. If the combination of 1 and 2 is proposed, then the residual QFR would increase to 0.76, which is already better. But by stenting lesions 2 and 3, we see that the residual QFR increases to 0.90. So that will be the optimal choice. And you see also after the 2 lesions have been stented that indeed post-PCI QFR is indeed 0.90. So this shows you how this technique can be used to really help the physician in making the proper choice in which lesions needs to be stented first. We are involved in many clinical trials for the QFR. There's the FIRE trial, as mentioned earlier. It's 1,400 patients that will be completed in September of this year. The objective is, the question is functionally driven complete revascularization superior to a culprit-only strategy in elderly patients older than 75 years of age? Of course, the FAVOR 3 study in China has been completed, 3,800 patients. The question is QFR superior to the visual interpretation? And the results will be expected at TCT of this year. We are working hard on the FAVOR 3 outcome trial. Question is QFR, and of course the hope and the expectation that QFR is non-inferior to the FFR in 2,000 patients in 40 sites, and currently we have included close to 700 patients. Professor Seruis is working on the Pioneer 4 trial in Galway. It's the QFR-guided Cinemat Supreme stent versus local routine diagnostic procedure and usual care. 2,540 patients in 30 sites in Europe, and also on the multi-talent trial from Galway. It's a QFR core lab guided stent placement Supraflex from SMT company versus the Synergy stent. First inclusions were in January of this year, and that's also a total of 1,550 patients in Europe, sorry, in 60 sites. I would like to show you also, this is a very recent PowerPoint presentation from Professor Campo, where he wants to test the efficacy and the safety of QFR. He calls it now QFire, combination of QFR and the FIRE study, very nicely found, to test efficacy and safety of QFR in non-STEMI and STEMI patients. Now in this case, of course, there was a culprit lesion that was stented, but there are still in the other vessels also lesions where the QFR can be calculated, in this case 0.85 and 0.82. So also a very interesting study. There's a lot of clinical evidence on the QFR obtained over the last so many years. In the meantime, more than 115 peer-reviewed scientific publications. I think it's includes now more than 15,000 patients. These are a number of interesting publications that I will not go in all the details, but as you can imagine that the QFR so far has been tested predominantly on European and Asian patients. Recently from MedStar, a medical center in Washington, it was also confirmed that this also works very well in the American population, where also the QFR accuracy in agreement with FFR was also with a high accuracy of area under the curve of 0.92. I would like to mention the study by Dr. Chubrite, where compared to FFR as a reference, she found that the fluoroscopy time was almost half in QFR and almost 1/3 of IFR time, and also the dose area product was the lowest for QFR. For example, also Dr. Hernan Mejia Renteria from Madrid showed that compared to FFR, that the QFR has a high diagnostic yield and superior to angiography in assessing the functional relevance of corneal lesions in patients with severe aortic stenosis awaiting TAVI, also an area of high clinical interest, of course. A few words on the latest version of QFR. As you know, that the frame count is an important step in the analysis, where we need to decide how long it takes for the contrast to travel through the vessel. That's a manual procedure so far. We have been able to automate this, and we call that automated frame count, which is a smart algorithm, which determines also from the two views that you have, which has the best quality to calculate, to assess the frame count. It also has a quality algorithm, which decides whether the algorithm is solid enough, and in the less than 10% of the cases that it may not be, then the algorithm returns to the fixed flow velocity or the manual frame count. And also what is extremely important now, that the automated frame count provides also the actual coronary flow velocity through the vessel. And that opens now opportunities for an angio-based assessment of coronary microcirculatory resistance. And in this session, we have heard already several presentations about the relevant and the importance of assessment of microcirculatory disease. And also we have improved the contour detection with less interaction, even in cases with poor image contrast. And as a result, the QFire analysis can now be done in less than 1 minute. I would like to show you a very short movie that shows you indeed this analysis time. And as you will see here, the counter is counting the seconds, the two views. We select the QFire application. You see here the two RCA. Also, if there is ECG, there's automated detection of the end diastolic frame. To align the two views, we need a marker that we select in the two views to align them and determine the three-dimensional spatial position. The path line is detected automatically as well as the contours. And if needed, we can make a very simple and quick correction to the contours if needed. In the meantime, the auto frame count is working on the data. And we see here the diameter function and selection of the lesion. And we need to select whether this is the left system or the right system. And here you see already a QFR of 0.78. And in this case, we will select now the proper stenosis here with a residual QFR of 0.97. So if that particular stenosis here from the beginning till the end is treated, then we can obtain an excellent result. As I mentioned earlier, we are now very close to assessing also the coronary microcirculatory resistance. The only additional information that is needed is aortic pressure. So if we have the aortic pressure and we multiply that by the QFR, we have the driving pressure at the end of the vessel. The flow velocity is known, and that means also the mean transit time. Putting everything in formulas results in an angio IMR of 28, and so far we use the same threshold as used for in the pressure and temperature fitted, say the guide wire approach, the invasive approach, where in this case also a value of 25 was found. So this has been initially validated and published in Catheterization and Cardiovascular Intervention recently by the group of Professor Eskenet and Professor Koo from Korea and Hernan Mejia Renteria, validated in 115 vessels and 104 patients with an accuracy of 85%. And further studies are on the way to confirm the initial very excellent, I would say, results. So in summary, I think with the QFire, it requires only 2 standard angiographic views. Of course, no wire, no adenosine. 3D QCA is available for stent sizing. Coronary physiology is available to select the lesions that cause the most significant pressure drops. It allows now also the assessment of microcirculatory resistance without an extra effort. And QFire avoids over or underestimation of understanding actually, and also pre-selection based on the diagnostic angiogram, all to the benefit of the patient. So now we can do it in only 1 minute. So what else do we want? I think this opens an enormous opportunities to apply QFire soon in clinical practice. And with that, I would like to thank you very much for your attention.
Very good. Very good. Excellent. Okay, so
sir, as we were discussing, we are fortunate to do this live demonstration of QFR, a multi-vessel PCI to the main TCT from our Apollo hospital last year. And we could finish the entire procedure of all the 3 vessels, including QFR, FFR comparison, and doing a results of PCI. And I'm happy to say that the QFR correlated quite well with the invasive FFR. And the problem of wire FFR also were demonstrated when we injected adenosine, patient got bradycardia and trouble. So it was a perfect case example to show the importance of QFR. And we had Vishwa, who has come from Medis, Netherlands, to help us during the calculations. And the software also provided free by Professor Reiber. Thank you, sir. But the only problem with this technology is neither with CT or with this is you need to get a good angiogram first. If your angiographic clarity is bad, cath lab images are not good, then you can't help it. Similarly, the CT. Obviously, you can't expect good things when your quality of imaging is bad, but that is where there is a crux. I think this is a great technology where in future, I wish it should become part of cath lab, every cath lab, so that what is right for the patient can be done, avoids unnecessary stenting, and it could become like a future QCA plus this modality that is the best for cath lab diagnostic modalities.